With the help of Abbott's breakthroughs, modern health.
Hello. Okay. Good evening, everyone. My name is Dr. Milin, and on behalf of Abbott, I welcome all of you to this Redefine Relief with Experts workshop, Emerging Trends in Management of Osteoarthritis. While we are in Mumbai, presenting live from here, we also have people joining in from multiple locations across India. I welcome all the people who have joined in from respective locations. We also have viewers joining in from OrthoTV website. I welcome all the viewers of OrthoTV to this event. And in the last, we have people joined in virtually through a web link. A warm welcome to all of you. To begin with, I would like to request Dr. Karthik to give a corporate presentation.
So a very good evening to one and all. I would like to welcome all doctors and my colleagues who are present at this venue, joined across 30 locations remotely, and those who have joined through our digital platform. The event or the scientific programs which we presently are conducting over here is termed as Redefining the Relief. We would have a galaxy of experts talking about the emerging trends in the management of osteoarthritis. Also, we would be unveiling the advantages of triamcinolone hexacetonide, the first ever molecule launched in India by Abbott. So before we go into the scientific feast, I would like you to have a brief prelude of what exactly Abbott is. To start with, Abbott is a global leader present in a diverse healthcare segments, which includes pharmaceuticals, nutrition, diagnostics, devices, and we are a team of close to 1 lakh people spread across globally, reaching out to 160 countries and been providing services for 130 years, and an annual net sales worth 32 billion. A basic principle of Abbott is to help people live fuller and healthier lives and also help them maximizing their potential at all ages and stages. We have a diverse portfolio providing life-changing solutions in various therapeutic areas, including cardiovascular care, diabetic care, diagnostics, neuromodulation care, nutrition, and branded generics. We would also like to emphasize the fact that in all these therapy areas, we are having leading or global leading positions, which goes to show the quality of the products that we provide, also the trust that the doctors and the patients that have on our products. Abbott's existence in India is for the last 11 decades, 10 decades, and we have been providing a portfolio of life-changing solutions. We have 3 manufacturing plants bringing quality products, reach faster, and one of the I&D centers, which is standard of care, providing solutions like Kenacort Hexa or triamcinolone hexacetonide for better patient outcomes. If you look at the branded generics market, our constant endeavor is also to provide high quality and trusted products which would help people stay healthy. And we, in all these portfolios which are listed below, which includes gastroenterology, women's health, cardiometabolics, pain management, and respiratory, the high-performing molecules are at least at a leading positions of number 1 and 2 in the Indian pharma market. In the long journey of providing the life-changing solutions to people, Abbott has won a lot of accolades. And to name a few, we have been the Fortune's most admired company since 1984. It is one of the best big companies which has been tagged by the Fortune. and also among the 100 best companies, which was being stated by the Working Mother magazine. Also, it is among the top 20 employer, which was being quoted by Science magazine. And that's a small snapshot of what services Abbott provides, and we strive constantly to bring out better patient outcomes. With this, I would hand over to Milind to take the scientific agenda ahead. Thank you.
Well, thank you, Dr. Karthik. As we all know that osteoarthritis is one of the most common joint diseases with increasing burden and significant disability. So let's learn from the experts who have been there and done that. It is an absolute pleasure and honor to have such an amazing faculty who are the experts in their respective field. We have Dr. Dilip Shah, we have Dr. Parag Munshi, Dr. Sachin Tapasvi, Dr. Rajesh Gandhi would be joining us. All are from Mumbai, joined from Mumbai. And we have Dr. Kevin Plancher joined us from New York virtually. And also we have Dr. Shashank Joshi from Mumbai who is joining us virtually. So let me take this opportunity to introduce the chairperson, Dr. Dilip Shah, who is the Senior Orthopedic Surgeon, FAAOA Hospital, Nanavati Hospital, Mumbai, ex-H&H Nair Hospital, Mumbai. He has vast clinical experience of more than 4 decades, recipient of SCIOT Fellowship, AO Fellowship, and Bombay Orthopedic Society Fellowship. He's the editor of many indexed orthopedic journals and examiner for the postgraduate exams. And he's also a member of many academic orthopedic associations. Welcome, Dr. Dilip Shah, and I request Dr. Dilip Shah to introduce and invite the first speaker, Dr. Sachin Tapasvi.
Oh, lovely. Good evening to all the people in India who have joined through remote access by the web, and Dr. Kevin Plancher. It was really a great coordination when we had a AAOS meeting, and when I saw your knowledge about this kind of injections, which could be Hexa. So I thought you'll be the right person. So welcome and good morning to you.
Good morning. Thank you so much, Dr. Shah. It's my honor.
Now, it's my duty to introduce Dr. Sachin Tapasvi. I mean, he's such a great man in India. Everyone knows, maybe by now, all over the world also, people know him well. He's a senior orthopedic surgeon, Sahyadri Super Speciality Hospital, Pune. He's president of Indian Arthroscopic Society, chair, knee, sports and preservation, ISHACOS, that is the Arthroscopy and Knee Surgery Association, associate editor of Journal of ISACOS, member of Newsletter Committee ISACOS, member of Publication Committee ISACOS, chairman of Sports Chapter of Asia Pacific Orthopedic Association, chief editor Asian Journal of Arthroscopy. I welcome Dr. Sachin Tapasvi. Tapasvi means a person who does a lot of meditation, and he will meditate and he will take you to a different height of knowing arthritis. Please, Dr. Sachin Tapasvi, give him a big hand.
Yeah, thank you so much, Dr. Shah, for your kind introduction. Thank you to all my friends here at Abbott. A good morning to Kevin. I don't know if he can hear me, but
I can hear you.
Yeah,
Good
hi
morning.
Kevin. Nice to meet you again. Hey, that's excellent. Hi there. Okay, so I'll be speaking on osteoarthritis, and it will be a prelude for the talk which is to follow by Kevin Plancher. Can we have the first slide, please? I think we're on the 6th or the 10th slide right now. Can we start the presentation from the first slide? Thank you. Yeah, I'll just get him to go start. Yeah. Okay, thank you. So I'm going to be speaking and I'm going to be giving a brief interlude on prelude on osteoarthritis, what really matters. And I think we're all here to discuss the non-surgical treatment of osteoarthritis. The knee joint particularly is affected more than any other joint when it comes to osteoarthritic process. And I think as a surgeon, we are definitely focused on surgical management, but I think it's really important to understand and treat non-surgically the patients that constitute a large bulk of our clinic. So osteoarthritis will go through various stages. You have the 4 stages as have been described by Kelgreen and Lauren. And essentially when we evaluate our patients, we look at their clinical staging and their radiological staging as well. What is important to understand is how do you treat patients who have bone-on-bone disease? How do you treat patients who do not have bone-on-bone disease but have early chondral softening and have symptoms which are really, absolutely give them a lot of problem with their clinical progression? They have symptoms that do not allow them to do their activities of daily living. So the basis of this discussion is that the treatment of osteoarthritis still remains an enigma because cartilage has limited capacity to heal. And with the various treatments that we use, we're trying to take care of this fantastic articular cartilage, which is what we try to repair or restore and try and help. So what is really articular cartilage? So cartilage essentially is about 80% 80% water and 20% protein. Of these 20% proteins, we have 2 major groups. We have the proteoglycans and the collagen. So your first modality of treatment is directed towards using collagen, which comprises of 2/3 of all the proteins, and that forms the first basis of your non-surgical treatment. If you look at the remaining 1/3, which are the proteoglycans, they provide compression strength, and these proteoglycans again are of 2 types. You have the core proteins and the aggregans. The aggregans essentially are the hyaluronic acid and the chondroitin sulfate, and these form now the second and the third basis of your non-surgical treatment plan. So when you're looking at non-surgical treatment, you're going to be treating either collagen or you're going to be treating the aggregans component of your proteoglycans. Why do we discuss all of this and why is it important? If you look at this publication, which came about a decade ago, which was published in Nature, they looked at the various diseases that have an impact on our life. And of course, you would be really surprised to find out that osteoarthritis is ranked very high amongst all the other causes to cause an impact on the quality of life. Essentially, we are way past 2020 despite COVID now, and osteoarthritis is almost a $60 billion industry. I use the word industry very cautiously, but yes, definitely there are a lot of innovations which are required. So when it comes to India, and this study was published by the WPC group, that is the White House and Price Cooper group, and they looked at about 100,000 patients, above 100,000 individuals above the age of 55. Almost about 25% of them had knee pain for at least 4 weeks in a year. Of those, a further 50%, which is 12,500, had knee pain along with disability. Another half of them had knee pain with disability with radiological changes, and 2,000 of them, or 2%, have severe knee pain with disabling arthritis. So essentially 2% of these people, and if you correlate that with the population of India, you have 2.7 crore Indians or 25 million people who have osteoarthritis, and these are the ones who require some form of surgical treatment. But what about the remaining 80%? Is it not our duty to try and help them out? And this is where we understand for sure that 80% of patients will have some limitation of movement. About a fourth will not be able to perform activities of daily living, and females unfortunately are more affected than men. So the symptoms that you need to sort out are pain, stiffness, swelling, and some form of instability and deformity, which needs to be treated by our non-surgical treatment. So osteoarthritis is essentially a multifactorial problem where you have issues which are metabolic as well as mechanical. And if you look at the metabolic part, I think it's very interesting to see that there is a lot of correlation between different metabolic diseases and how they influence osteoarthritis through a chemical and a hormonal pathway. I think it's difficult to discuss all of that in the next 15 minutes. The treatment pyramid of osteoarthritis essentially is stage 1, or the first stage is that we use good lifestyle changes and we advocate weight loss for all these patients. We then step up to using analgesics and topicals, following which we then move to bracing and insoles. Then we have various anti-inflammatories that we use in the treatment of osteoarthritis. Then we come to the most important intervention, which is injections. And then last at the top of the pyramid are surgical options, which almost about 2% of our patients do require. What about lifestyle changes and obesity? I think obesity is rampant both in men and women. Women in India are tending to be catching up on the obesity wave of the last decade or so. And hence, this has correlated into increased incidence of interventions, especially in women, more than men. What is definitely understood is that if you have a BMI of over 40, then definitely you're at a higher risk of getting a knee replacement, which is almost 30-fold more, and you have a higher risk of developing complications. And hence, lifestyle change and weight loss is something that we would always advocate. About pharmacological treatment, I think we are looking at 4 different categories of drugs. We're looking at analgesics, we're looking at topical therapy that can be used for all forms of disease from mild, moderate to severe. And if you are looking at opioids, I think they are reserved essentially for more of moderate and severe symptoms. And the opioids that we have access to in India are essentially buprenorphine or fentanyl patches. We don't have easy access to oral drugs, but opioid use is now established as a major entity in the US where they have where they're dealing with a lot of problems with opioid use, and I'm quite sure Kevin will allude to that in his presentation as well. If you look at the ORC guidelines, the ORC is the global group that looks into osteoarthritis. They published their guidelines 3 years ago, and they gave a word of caution is that if you do not have comorbidities, medical comorbidities, then you can use almost all of the categories of drugs that you see up on your screen. But if you have gastrointestinal problems, then you should be limited to what medication that you use. And this narrows down if you have cardiovascular problems as well. So you'll find here that corticosteroid injections are common amongst the 3 groups. And this is what we would discuss today as to how we can use them in our practice. Moving up the pyramid, we need to look at bracing and insoles. So when we walk, we have what is called as a dynamic knee adduction movement. And this is as a result of the ground reaction force that we have when we start walking. Essentially, what happens is that because of the adduction movement on the knee, the weight that passes up your joint is almost about 60 to 70% through the medial compartment. What happens in osteoarthritis, you develop a varus deformity, and now this dynamic adduction movement, almost 100% passes on the medial side of the knee joint, which results in a compressive force. Braces, do they work? Yes, there are some good studies that show that when you brace them with almost a 5-degree osteoarthritis unloader brace or a wedge insole and you compare them, you can find that a brace is more efficient to tackle or try and sort out issues on the medial compartment than a lateral insole, which has been demonstrated on a couple of studies. Can you move ahead to the next slide, please? Yeah, need some help. Yeah, lateral valgus insoles are also useful to decrease the knee adduction movement. But the problem with that is that they also increase the ankle eversion. And if you have increase in ankle eversion, then that may cause an abnormal load on the same. So the benefit of lateral valgus insoles probably is not that well established in osteoarthritis as is for unloader braces. And I think if you have to prefer either of them, try and prefer an unloader brace with which you can try and sort out the problems. We come to injections, and when we look at injections, I think you have to deal with the whole dream team. So injections, you have plentiful options, and I'm just trying to give you a brief overview of the various injections that you have. If you look at the various options that you have for intra-articular therapy, you can have drugs, you can have devices, or you can have drug-device combinations. Amongst the drugs, amongst the small molecules, you have the glucocorticoids, which will definitely form a big part of your clinical practice. Amongst the drugs and the drug-device combinations, you have a combination of hyaluronic acid alone or hyaluronic acid along with triamcinolone, which is also now being established as an intra-articular therapy for osteoarthritic knees. Amongst the biologics, you can have non-cellular therapy, such as the use of amniotic membrane or interleukin-1 inhibiting factors, or you can have the extended cell therapies, including the gene therapies, which are essentially blood-derived or adipose tissue-derived injectables, which we use in our clinical practice. But when we talk to a room with all the big injections, I think corticosteroids is the elephant in the room, which we cannot ignore, and definitely this needs to be looked into in more details. Brian Cole published a good study in arthroscopy where he looked at the various clinical practice guidelines for non-arthroplasty treatment of osteoarthritis, and definitely when you look at the end stage group as well as a broader group, corticosteroid injections did form anywhere between 16 to 43% of all injectables, as against Visco, which was somewhere between 6 to 15%. Corticosteroids, as we know, are non-biologic. They are non-reparative or non-regenerative, but definitely useful. Another study that was published in the Journal of AAOS, they looked at a multi-center study of 100 participants, which were treated with triamcinolone as well as 1% lignocaine, and they showed definite improvement in their VAS scores at 6 weeks and 3 months. Of course, it's a no-brainer that the more obese you are and the more advanced disease you have, less will be the improvement in your clinical scores. Mohit Bhandari again did a very good network meta-analysis of almost 61 papers, a level 1 study, where he looked at the differentiating factors of intra-articular injectables to have a meaningful impact. And his conclusion was that extended release corticosteroid injections have much more additional clinical benefit over standard release corticosteroids, which is something that we need to look into. We have always this risk whether corticosteroids, once injected, will cause infections. And again, this publication, which came out of the Journal of Arthroplasty, showed that in a systematic review and a meta-analysis, there was no increased evidence of superficial or deep injections. So much so that the Canadian Arthroscopy Association went on to publish a position statement 2 years ago where they recommended intra-articular steroids with a strength of recommendation of good or an A grade category. This is important to understand because it becomes a cost-effective treatment which allows for restoration of function. We next look at viscosupplements, which again are an important injection that we use in our clinical practice. It may be either animal-derived or bacterial-derived. Viscosupplementation helps temporarily in restoring lubrication and shock-absorbing effects. So the evidence essentially is that you do have a lot of conflict of interest because almost 2/3 of studies do have some form of potential conflict because of the manufacturers who are involved. So a Cochrane review did show that it is more effective than placebo with relatively fewer side effects. Another good publication where they looked at the ORC guidelines, they looked at a meta-analysis of almost 54 trials and showed that the peak effectiveness of your viscosupplementation injection is usually around 2 months, which then gradually diminishes by about 3 to 6 months. What is important to understand that all viscosupplementations are not the same. It depends whether you are using, what sort of cross-linking are you using and what sort of molecular weight are you using, because that has a huge influence. So please be sure to read the fine print of the drug that you're about to use before proceeding with the same, which is what needs to be sorted out. Again, if you look at all the guidelines that are being published, you can see now that viscosupplementation has got a stronger recommendation over the last 3 to 4 years, which is then making sure that it is also establishing itself in the non-surgical treatment of osteoarthritis. The next injection therapy that is used is platelet-rich plasma, and PRP, as we know it, acts through a variety of mechanical pathways. Essentially, what is important to understand is that you manipulate blood, and this blood is then centrifuged to form plasma, and this plasma is then used to stimulate cells of the cartilage, synovium, and the ACL, and to increase what is called as the superficial zone protein secretion, and of course to decrease the coefficient of friction, which is what it is used. If you look at the literature that is available now, we see that HA equals PRP, and though you may have a lot of studies which do show that this is better than the other, essentially what we have is that both of them are absolutely the same. What is important now is to start looking at these drug-device combinations, which is essentially combining HA with PRP or HA with corticosteroids, which then have a dual mechanism of action, which then lead to a longer and more prolonged outcome, which is what we want. The next cell type are the mesenchymal stem cells, which were discussed and described by Arnold Kaplan. But what is important to understand that these mesenchymal stem cells have had a change in the way we look at them. These MSCs are no longer called mesenchymal stem cells, but they're actually called as medicinal signaling cells, and that is what MSCs now stand for. These work by recruiting other stem cells, secreting bioactive factors, and by causing local modulation. And the source that we use is that of adipose tissue, because we can harvest adipose tissue in a minimally invasive fashion by doing a liposuction. And I think if you ask me, I'll be happy to donate a lot of my fat that I have on me right now. So adipose tissue is probably the best source of MSCs, and that is why adipose tissues are now manipulated to be formed into an injectable form, which is used inside the knee. So orthobiologics in the knee are definitely important, but they're really hampered by a lot of regulatory process, and there is the unfortunate bad side of medicine industry, which is also involved in the same, which may have some questionable ethics. Lastly, for those 2% people where you have advanced osteoarthritis, I think we need to look at surgical treatment options as well. So with this, I think I will end my presentation, where this was a simple prelude for all of you to look at what the various treatment options are. And in 6 weeks from now, I think we have a very good meeting that we will host in Pune, where we look at all of these problems, starting from basic cruciates, meniscus to advanced osteoarthritic treatment. And I'll invite all of you to be a part of the same. Thank you so very much. And I hand over now the podium to Dr. Shah for the next proceedings.
Just to give you an update, all of you, currently we have 900 doctors who have joined in virtually and attending this event. Over to you, Dr. Shah.
Hi, Dr. Kevin Plancher. You are the next speaker, so let me introduce you. And I must thank Dr. Tapasvi that he took us from ground zero level to almost 40,000 feet high. And I don't know, he would have gone still higher up, but then that's beyond our capacity at this moment. But he talked about the future also. Dr. Kevin Plancher, sir, you are the founder, Plancher, Orthopedics and Sports Medicine, New York. You are a clinical professor, Department of Orthopedic Surgery, Montefiore Medical Center, Albert Einstein College of Medicine, Bronx, New York. Adjunct Clinical Assistant Professor, Orthopedic Surgery, Vail, Cornell Medical College, Cornell University, New York. Past chair, Board of Specialty Societies, American Academy of Orthopaedic Surgeons, where I had a wonderful encounter with you and I saw a very sparkling kind of speaker. That's why you are here today. Editorial Board, American Journal of Sports Medicine Principal Reviewer, numerous publications in peer-reviewed journals and book chapters. Dr. Kevin Plancher, over to you, and let's listen to a person who is well experienced about injections which are hexacetone with triamcinolone. Thank you very much.
Dr. Shah, I'm truly honored, Dilip. I'm sorry that I'm not there today. And I can't thank Sachin, Dr. Tapasvi. What an incredible introduction into the world of non-operative treatment in osteoarthritis. I wish I was sitting in the room, and I wish everyone great health and all the physicians that are listening on. And I hope today to share with you some of my thoughts on arthritis. I'm going to share my screen now, so just give me one moment. Just one moment. Just move this out of harm's way. So my charge today is to talk of the role of intra-articular corticosteroids in osteoarthritis, new concepts, and as well a focus specifically, and thanks to the Abbott Corporation for bringing to India triamcinolone hexacetonide. It's a glorious day for health of the doctors and the patients they're going to treat. Going to see if you can release so I can advance. So let's go. What do we know? We know, as you just heard from Sachin, that osteoarthritis affects 25 million people in India. I'd like to share with you in America, 32.5 million Americans are affected, no different than what's said before, that women are affected, unfortunately, more than men. And the reason people are paying attention is because it's an industry that costs us 185 billion. So we are important in the world, and that's really exciting because we can make changes. Knee osteoarthritis is the most common work-related disability for our population aged 18 to 64. And you find it interesting that when an arthroscopist goes inside the knee, 63% of the time, these patients have global chondral damage, but not bone on bone. And the question, as we'll explore today, is how can we help them? And I think I have an answer. And one of the great answers is truly the triamcinolone hexacetonide. Also, you'll find that isolated chondral injuries of the knee do occur. And it's occurring in about 5 to 10%, as it says, in patients over the age of 40. 1 million Americans are affected annually, and 200,000 procedures are done each year to try and make sure that we resolve these symptoms. In arthroscopy, 20% of the time the patients suddenly have this defect, and in our elite athletes, our soccer players, football players, it's up to 36% of the time. And so that is a very alarming problem for us. I'm just going to try and see. There we go. Where does it affect most of the time? You heard about the medial varus knee. It's the medial femoral condyle that is really affected most of the time. And it's the patellofemoral joint, only 20%, and the tibial plateau that can be affected as well. So what does the American Academy of Orthopaedic Surgeons say? They've said a while ago in 2018 and 19 that extended release intra-articular steroids can be used over immediate release to improve patient outcomes. And I tell you, that's what we're going to talk about today, the extended release. But they do all agree in 2021 that for short-term pain relief, intra-articular corticosteroids are the best answer, and I'll show you why. No different than what you saw before. Here's my pyramid again, well explained by Sachin. Patient education always comes first. Physical therapy, occupational therapy, weight reduction programs already spoken about, non-steroidals, vitamins, hopefully limiting opioids always, moving up the grid for viscosupplementation, PRP, adipose, well spoken about and at a high level. But I want to focus on intra-articular corticosteroids. And many of you in India may be using prednisolone, maybe some triamcinolone acetonide, but I want to focus and show you why the answer is going to be triamcinolone hexacetonide today. We went through, so I'll limit it again, an outstanding again presentation. I didn't know that Sachin, Dr. Tapasvi, would show us the extracellular matrix that provides, I think of it like an ice skating rink. You throw a penny across that ice skating rink, the penny floats across the ice skating rink. People skate on the lake or the rink, and suddenly we have dents and divots, and suddenly we can't skate. Our Zamboni comes along. We don't have that answer. But what we do have is sometimes injections of hyaluronic acid, chondroitin sulfate, as well as solving the problem even better with an intra-articular corticosteroid. Because in understanding arthritis, we lose that synovial fluid due to synovitis, decreased synthesis of the hyalurons, and that is what is chondroprotective for us, that lets us succeed every day without pain in our knee. So let's explore what we have to do as we move up the pyramid, specifically from mild to moderate to severe, and each way how we can really intervene in treating knee osteoarthritis. I need to start back in 1986. Someone a lot smarter than myself said the first line of treatment, and we know it, of after unsuccessful physical therapy, in 50% of patients before total knee arthroplasty is an intra-articular steroid injection, 24% before knee arthroscopy. But what they noted when they injected a routine short-acting intra-articular steroid is 19 days or thereabout after the injection, the plasma concentration was gone. Therefore, it was out of the joint. That's a standard steroid injection at 3 weeks. Then it gave 4 to 6 weeks of standard relief. And all of you know that sometimes we have patients that get relief longer than that. But I want you to know the science of where the drug is, and it is truly gone. We'll come back to that at the end of our talk. So short-acting corticosteroids give short-term pain relief up to 4 weeks, whether you're a user of methylprednisolone, triamcinolone acetate, betamethasone. These are commonly used intra-articular injections, and I believe in India, methylprednisolone acetate is commonly used, as well as triamcinolone acetonide. Do not forget that whenever we cause no harm, we have to know and elevate our patients so they're educated that sometimes some of these early intra-articular steroid injections do give elevated blood sugar elevation. And so the caution is, for those of you using these short-acting steroid injections, you're hesitant, and I know you are, to safely give them to the diabetic patients. We try to avoid depigmentation by injecting correctly, not close to the skin. And we do know the long-term effects of all of these intra-articular steroid injections. And that's why a safety program and safety profile, as we'll talk about with triamcinolone hexacetonide, is so important to help you. The duration of action here of methylprednisolone, you can see, is about 7 days. Triamcinolone acetonide is 14 days. I'm going to show you how much longer triamcinolone hexacetonide is and why, therefore, with the mean residence time, you want to consider changing your clinical practice, and that's what we'll discuss today. So if I can propose to you an intra-articular corticosteroid that gives you rapid pain relief, it increases mean residence time, but it stays in the joint and decreases outside the joint in a plasma concentration, which would indirectly say to you that it would be safer in a profile for a diabetic, and now gives you long-term sustained response for 24 weeks, I hope you'd agree with me that you would say, that's something I want for my patients. So enter triamcinolone hexacetonide. Let's talk a little about the pharmacology first. I'm talking about an intra-articular injection that's a long-acting glucocorticoid. I want you to consider the dosage of 20 milligrams per ml, and safety programs were done and testing at a higher dose rate. This is an injection for your large joint, hip, knee, shoulder, medium joint, wrist, elbow, smaller joint, fingers, triggers, for osteoarthritis, post-traumatic arthritis, rheumatoid, juveniles, and other areas. I'm going to focus today, though, on osteoarthritis for this as an anti-inflammatory and a really excellent intra-articular glucocorticoid. Look here at the systemic absorption at 3 days. Triamcinolone hexacetonide, only about 35%. For the beta-methazone users, it's about 78%, and for triamcinolone acetonide, about 58 to 67%. So here, the longer duration of action, less peak levels of steroid leading to less systemic exposure is only something that all of us, I believe, want. Triamcinolone hexacetonide versus others, you can see here the longer duration of action up to 90 days, 66 for our acetonide and methylprednisolone, about 56 days in many articles that have been published previously. How about a safety profile? We'll start there. I'm telling you that triamcinolone hexacetonide, because it deposits, and we'll talk about its absorption, is extremely low in the systemic plasma. Because of, you'll see what it can do, it's insoluble. Its anti-inflammatory potency is approximately 5 times that of hydrocortisone. And what we care about is it has practically no mineralocorticoid effect, so therefore no sodium retention. So I would say it's pretty safe for your cardiovascular and renal patients. Here you can see some pain scales on a VAS score and health assessment questionnaire for triamcinolone hexacetonide versus placebo. Clearly at baseline, week 1, week 6, whether a health assessment from the patient or from a VAS score, lower scores for triamcinolone hexacetonide versus a placebo. How about a study of prednisolone, methylprednisolone, triamcinolone hexacetonide, looking at 42 days to see exactly a single intra-articular injection that was given to the knee in rheumatoid arthritis, making the criteria obviously of ACR, and then looking at thermograms, so heat that exudes, you'll see and I'll show you, and then estimating what the symptom relief was. In this study of outcomes of a single intra-articular injection, the greatest reduction was truly at 1 week, and only triamcinolone hexacetonide maintained the significant reduction at 6 weeks, with a mean fall in a thermogenic index of the affected knee. If you've never seen what a thermogenic index is, here's some of the math, and the blue would represent relief in the knee as opposed to the red waves. And the study was done a long time ago to show that these thermographic changes in skin temperature have relationships to clinical outcomes and showing what is better. The duration of action I talked about is long for triamcinolone hexacetonide, statistically significant. It is insoluble in water. And here you can see its duration of action. It is insoluble, no different than triamcinolone acetonide and methylprednisolone, but notice the action and the duration of action. The rate of absorption and duration is related, obviously, to the solubility of this compound. Here, another study of an intra-articular injection in a symptomatic knee arthritis, methylprednisolone at 40 milligrams, triamcinolone at the dose we're suggesting, over 8 weeks, 20 milligrams, in KL radiographic 2-3 knees. Here we excluded severe bone-on-bone osteoarthritis to take a look at changes at VAS scores as well and compare the three at 8 weeks. You can look at 3 weeks, over 80% of the patients felt better in both groups. At 3 weeks, groups saw improvement, but at 3 weeks, it was significantly better than methylprednisolone, and the differences there with improvement, more effective, longer term, as we come out of the gate for 3 weeks. How about some clinical evidence supporting long-term and sustainable response with triamcinolone over 24 weeks? Here, taking triamcinolone and methylprednisolone in bilateral asymmetrical knee arthritis, the dosing of a single injection, we're going to look at WOMAC scores, more important sometimes for me than pain scores of VAS at 24 weeks. And so, here you can see the VAS scores, the pain scores once again change from baseline at week 2 that was carried out all the way out to 24 weeks, but statistically significant WOMAC scores that was carried forward up to 24 weeks. Therefore, the efficacy of triamcinolone hexacetonide peaks at 2 weeks after the injection, and it continues on for 24 weeks. And who knows, because we know with our short-acting injections, people sometimes get 6 months or they claim 1 year. This is a game changer long-term. Safety profiles, no adverse effects in multiple studies, randomized controlled. Here you can see other studies that have been presented, case-controlled prospective studies that really have not shown problems and therefore a high safety profile that you're going to care about if considering using it. I'd like to share my personal newer thoughts for a minute in my practice. You heard Sachin talk a little about it. I am a big user and belief that intra-articular corticosteroids give superior pain relief, but I'm also a believer that hyalurons, and I'm not attached as a consultant, I do not get paid by any hyaluron company, that improvements can begin later on at 2 to 5 weeks. So my mentor, Dr. Stedman and Vale, back in 1994, started saying, why not inject both together for fast pain relief and functional improvement? Well, it turns out that triamcinolone hexacetonide was picked up by another company. Here an article, you can use the QR code, and you heard about it on a slide. If you combine in KO 1 through 3 knee osteoarthritis, triamcinolone hexacetonide, and in this case combined it, this was commercially combined with Monovis, there was huge reductions in pain scores and long-term relief once again. Why? 26 weeks? Probably because of the triamcinolone hexacetonide. And that's what we're here to talk about today. But I encourage you to sample, and you can, if it's not commercially available, as it's not in India, you can consider these combination injections with a safe profile. But I would heed the words of Sachin, not all HAs are the same. I'd also like to talk about blood glucose. Triamcinolone hexacetonide is very exciting. If it stays in the joint, gives less chance to elevate blood glucose. And this theory has been sought out and proven from other medicines that exist in the market in other places in the world. So we know if you do a long-acting intra-articular corticosteroid that we can safely inject into our diabetics as opposed to the short-acting intra-articular corticosteroids, which do elevate the blood glucose. I think it was touched on by Sachin, and I want to dwell on it because some of you are going to be fearful of giving intra-articular corticosteroids and forming infections. And I'm here to say that prior to 2016, the literature was really inconclusive. There were so many studies showing a greater risk of infection after a total knee, other studies saying no greater risk, and who knew with hyaluron because no one knew. So let's share some science together if we can. Here a study by Gil Scuderi, a friend in New York City, and welcome, because I do come from New York City, and I encourage you at any time, if you have the honor to visit. I've had the honor to visiting Mumbai twice and being in person, and I look forward to coming back to India and sharing my thoughts in person. He looked at his total knee patients, injection versus no injection of an intra-articular steroid. The timing, he said, 0 to 3 months, 3 to 6 months, 6 to 9, 9 to 12, greater than 12. He found no significant difference between groups if he injected of yielding an infection. And his conclusion, can you use preoperative intra-articular injections of steroids? No increase in post-op infection rate, and it didn't matter the timing. Well, another article came along, a systematic review of 350,000 total knees, some with an injection, some not with an injection, and the risk of infection depended on timing. In this article, where these authors said the patient receiving an intra-articular injection should wait greater than 3 months before undergoing a total knee arthroplasty to minimize a risk of infection, then they were blaming the intra-articular injection. Dr. Callahan, one of my colleagues and former president of the American Academy of Orthopaedic Surgeons, wanted to look at it, but he looked at a database. And I caution all of you when reading articles from databases, because you can't get at some of the details. You don't know what injection was injected. You don't know how it was injected, but nonetheless, these are existing in the literature. 83,000, as you can see, with 54, no injection, no demographics difference. Injection prior, taking a look, there was a higher risk, he said, of superficial deep post-op infection and a higher risk of return to the operating room within 6 months after total knee if you injected. His summary confused us more and said studies suggest you have to wait 6 months before a total knee arthroplasty to the last injection to decrease the risk of post-op infection. So along came Dr. Skolko, the son of Tom Skolko, the former surgeon-in-chief of Hospital for Special Surgery. Again, unfortunately, looking at a Pearl Diver database, 58,000, looked at injections within 1 year of a total knee, as well as less than 3 months, looked at if it was a single injection or a multiple injection. And they had, as you can see, corticosteroid injections, hyaluron injections, and the total injection rate was 2.83%, and injections within 3 months showed an odds ratio of about 1.21, with no difference whether you put in hyalurons or corticosteroids, and no increased risk of infection whether you did 1 injection or more than 1 injection before a total knee. Here, what we did learn is those patients who are male, less than 50 years of age, have a greater risk of infection, and so they suggested to wait a minimum of 3 months before doing a total knee arthroplasty because of a risk of a post-op infection. So I hope you're a little confused, because I'm confused terribly, because I think I understand pharmacokinetics. I'd like you to think about this. Why is it that people are trying to make a casual link to infection? Drugs like the traditional corticosteroids, the intra-articular injections, are eliminated from the joint at 21 days. Why are we holding steroids responsible at 6 months post-surgical intervention when the drug is nowhere to be found? I don't have an answer. And even the newer agents with average synovial fluids, they're quantifiable at 12 weeks. They're undetectable at 16 weeks. Yet we're holding the drug, the intra-articular corticosteroid, responsible. I tell you that's a wrong thought, and it's to be continued. So I'm still gung-ho on giving intra-articular injections, and I don't wait and I don't care. It could be the same day or even a week before. So are intra-articular injections, are they safe? They're terrific for younger, middle-aged patients. I think you should consider mixing triamcinolone hexacetonide with a hyaluron as well, and maybe experimenting with a PRP. I do not believe there's an increased risk of infection. Our study is going to come out with our cohort. I think single surgeons have to publish, and more prospective studies are definitely needed. I think as you go up the pyramid, triamcinolone hexacetonide is going to win out over pregnenolone and triamcinolone acetonide in India because they're available. It's safe, it's effective, has a longer duration of action. It's not cardiotoxic. It's not bad for the renal patients. It's probably safe for some of your diabetic patients, more so than the short-acting because it's held in the joint longer and not in plasma and then gets disintegrated to carbon dioxide and water. So triamcinolone hexacetonide is comparable in efficacy. It scores higher because it absorbs lower than the currently available intra-articular corticosteroid with the lower systemic corticoid levels. It's better with its intra-articular duration of action, I believe, than methylprednisolone and triamcinolone acetonide. It's less soluble within the synovial joint, as we talked about, increasing the mean duration of time. It's a winner. It's just that. Some of you are going to ask me, do I use ultrasound or not? I will tell you for the knee, I don't. For the shoulder, I do. Younger people and non-operative orthopedic, non-operative surgeons, so family practitioners and people are skilled at using ultrasound. You can. I'm not sure. But for those arthroscopists, I think the injection is an easy thing to do for me. But I would say whatever makes the injection accurate, you should do. I'd like to share this case of this morbidly obese woman, probably famous, type 2 diabetes, high blood pressure, current medicines, bilateral knee pain, 2 grandchildren, wants to bend down to the floor, had an antalgic gait with a varus thrust, pretty good motion, medial joint line tenderness, no ligamentous laxity, and pain on hyperextension and hyperflexion. X-rays showed clearly narrowing of the joint, but not bone on bone. It is this patient that I am going to give an injection right away and hope that she can help with a weight reduction program because movement now increases. I think triamcinolone hexacetonide is the one I'm going to go because it's longer acting. And I think it's safe even with these comorbidities, as I talked about for the reasons that I gave and we can talk about in the panel. I think intra-articular corticosteroids are wonderful. They don't harm the joint. They don't deserve to get the idea that just because in rats the cartilage went away. It's not true. And I don't use it to abuse it, but I think triamcinolone hexacetonide is the answer for you. The AAOS guidelines show in 2021 extended release intra-articular steroids over immediate release. You should think about. You should think because it's slowly hydrolyzed at, as it says mechanically, the C21 position to the active component. It has low solubility, high residence time in the joint. It gives pain and function effectiveness because it's long duration, and you know that it does it for several weeks and 24 weeks. So I can't thank you enough for spending a little time with me today. I apologize for not sharing in your wonderful country in India. But these people in America were building a bridge. Do you think they were that smart? It took them this long to figure out that the two sides would never meet. I think we as professionals are a lot smarter, and I hope I've opened your mind today to think about what you're doing in your clinical practice and to perhaps change in a safe environment to help your patients to only do better. Thank you very much. I don't hear you.
Can you hear me now?
I sure can. Thank you so much.
Thank you so much for the wonderful session. There are certain questions from the audiences which would like to ask. One is key. What is the minimum duration of a gap between the two intra-articular hexaconide injections if a patient require?
So I guess the question is, can you repeat an injection one after another, and when do you do so? So I'm going to say what the safety profile will say second, and then I'll tell you my personal answer. I have to be biased because I'm an orthopedic surgeon, and I don't know of the 900 wonderful people viewing those who are not orthopedic surgeons who use wonderfully intra-articular corticosteroids. So I am a person that gives a maximum of 2 injections, but the first injection, I want to see the result. If the result is, as I suspect, long-term, which is 3 months, 4 months, whatever it is, if someone comes back, I'm going to give that injection. If I find that the result, for whatever reason, is 7 days and they feel that it's not working, I have to give credence to thought that I missed something on the x-ray, that I perhaps have a bone-on-bone relationship, and that's why x-rays, I think, are important. I think the answer is that the Abbott Corporation, I think, is doing a study on repeats, but I will tell you with triamcinolone acetonide PLGA, which was a different product, they showed that safety profile allowed for 6 to 8 weeks for a second injection. And so I may turn to the Abbott Corporation for that science, but I know that you can safely do that, watching your comorbidities. And I think I would be easily able to do it, but I would want it not before 24 weeks or 28 weeks, because that's the exciting part about this new injection.
Thank you so much. There is one question from Dr. Praveen, and he's asking, does the dose of triamcinolone hexacetonide depends only on size of joint or severity of condition, or are there any other factors which decide the dose?
Right. So at the moment, the pharmacology, again, is at 20 milligrams per ml, but the studies were done at 40 to look at safety profiles. And so available in India at the present time is 20, and I would not change that since many of the studies have been rigorously looked at.
Dr. Plancher, there are not only questions in a chat box, but there are words of appreciation for the talk from all the audiences from India.
Oh, that's very kind. As I said, I have made great friendships, and with Dr. Shah and his kindness, he's overly kind, and many others, whether I've gone to Mumbai and other cities, it's always an experience. I've actually operated in your country. I had that honor, and so I love working with the young doctors and training them in procedures. So I look forward to that day to come and returning again.
Thank you so much, Dr. Plancher. With this, we move on to our next sessions of a panel discussion. For this, I would like to request Dr. Rajesh Gandhi, the President of Bombay Orthopaedic Society, to introduce the panel members and the moderator, Dr. Parag Munshi.
Good evening, everybody in India, and good morning to you, Professor Plancher.
Good morning, sir.
After a very absorbing session with Dr. Plancher and Dr. Sachin Tapasvi, we now move on to discussion, panel discussions, and question-answer sessions. I would like to introduce Dr. Parag Munshi. Dear friend, Parag Munshi is a senior orthopedic surgeon from Bombay Hospital, Bridge Candy Hospital, Mumbai, since 2007. Prior to that, he has worked in UK after finishing his FRCS and M.CH ortho training in UK. He has a specialty fellowship trainings in arthroplasty, lower limb surgery, and a shoulder surgery. He has numerous publications in index journals like JBJS, Clinical Orthopedics, and he has been a faculty for many national and international conferences. I invite Dr. Parag Munshi. Please come. Dr. Shashank Joshi is another panelist. He needs no introduction. The dear friend He has been a Padma Shri awardee in 2014, the highest civilian award, one of the highest civilian awards which he has got for the services to the medical fraternity. He has been an endocrinologist at Joshi Clinic, Lilavati Hospital, Apollo Sugar Clinic, and Bhatia Hospital, Mumbai. He has been a past president of Association of Physicians of India, 2014-2015. He has been a past president of Endocrine Society of India in 2015 and 2016. He has been a past president of Research Society for the Study of Diabetes in India in 2011. He has been a past president of All India Association of Advancement for Research in Obesity. He is emeritus editor of JAPI, Journal of Association of Physicians of India. I welcome Dr. Shashank Joshi. He has been not amongst us, but he is virtually present with us. Thank you. I invite Dr. Parag to moderate the session. I invite Dr. Dilip Shah to come on the stage, please. Dr. Sachin Tapasvi, please come on the stage.
Changing the slide. So this is better. Chalo.
Okay. So, Dr. Kevin, can you hear us here from Bombay?
I can very well. Thank you so much, Dr. Munshi.
Okay. Thank you for your wonderful talk. Now, this is a session where we want to get the panelists talking about their experiences about treating OA conservatively. And certainly we want your inputs on certain scenarios which we see here in India and your inputs in terms of the academy recommendations. So we've strung up a couple of cases together here to bring out certain points, and we'll see what the view of the panelists are on these topics. So we've got this first case. So we have this lady, she's about 48 years old, housewife, known diabetic and obese, BMI of 31, OA since last 4 years. She was treated with conservative management, including analgesia, physiotherapy, weight loss programs, etc. No progress. She then received a shot of hyaluronic acid 6 months back. That too really did not help. So she's been a diabetic for the last 6 years with an HbA1c of 7.5, significantly handicapped in terms of pain scores and pain at rest as well. And then she gets these episodes where the knee swells and settles. So this is the X-ray which we've got. Now, so the first question is, how common is osteoarthritis in diabetic patients? And is there a direct link between the two? So I'm going to get Dr. Shashank Joshi to talk to us first, since he's been a passive observer all this while. Dr. Joshi, can you hear me?
Yeah, loud and clear.
So in your clinical practice, how often do you see diabetes and osteoarthritis occurring concomitantly?
So in people above 50, particularly in an urban environment like Mumbai, and my apologies, I can't be with you in person because I just landed back from New Orleans with the COVID. So I'm stranded at home. So every third person in a person above 50 who lands up in a clinic like mine, who is obese with diabetes, has some form of or some degree of osteoarthritis. So clearly it's a very common problem, and it's has a gender predilection to women more than men. But it is something which we observe in almost 30% of cases above 50. And if the obesity is overwhelming and the BMI is above 30, as what you have alluded in the case, the percentage of osteoarthritis goes above 50%. So clearly it is 1 in 3 or to 1 in 2. That's the general prevalence of osteoarthritis in diabetic population or people living with type 2 diabetes.
Okay, so there is a direct link between diabetes and obesity and osteoarthritis. So is diabetes an independent predictor for severe OA? So if one looks at data, there is a direct link. So there's a population-based cohort study which shows that the risk increases if you're a diabetic. And type 2 diabetes emerged as an independent risk predictor for arthroplasty, with the hazard ratios being pretty high. So we need to warn diabetics, particularly if they're overweight as well, that they are heading for trouble. Now, going back to the first slide, I'm going to ask our panelists here. So let's start with Dr. Dilip Shah. So we've got this lady who's 48. Now she's significantly handicapped. This is what we've got in terms of X-ray. We don't have any MR imaging, etc. What would you offer her at this age now and at this stage?
Control of diabetes first, reduce the weight, a lot of physiotherapy to improve the quadriceps muscle, change the lifestyle, and if she has not been happy with intra-articular hyaluronic acid injection, I would try triamcinolone hexacetonide along with a visco supplement of my choice. Maybe you can add Hyalgan GF20 or whatever you prefer and see the results. In spite of that, if this does not improve, then we'll talk later on. Let other people also answer this.
Okay, so he's just said that the HbA1c of 7.5, he's not very happy. Dr. Joshi, do you think this HbA1c is reasonable or would you strive to bring this down further?
So this A1C is reasonable, but I would have loved to keep it below 7 or 6.5. But that won't preclude me either to take a decision related to a steroid like the one which was discussed, like triamcinolone hexacetonide, or even surgery. So 7.5 is reasonable. It's not going to be compelling enough for me to hesitate to start the intra-articular steroid, particularly because it's a very localized preparation, and the pharmaceutical chemistry, beautifully alluded by Kevin, clearly alludes to that. And therefore, at 7.5, I'm okay. I would just modify the medications. We have 3 good classes of medications now in diabetes, which make you lose weight and also get your A1C down. One of them is an oral class of agents called the SGLT2 inhibitors. Another one is an oral GLP-1 analog, which is also now available in India, called Rybelsus. And the third one is the injection of GLP-1. So, we may do some fine-tuning of the medications given to the patient so that we get weight loss as well as A1C coming down by the time you all can handle the joint.
Okay, so let me get Dr. Plancher in. What would you offer? Hello, can you hear us?
Yes, absolutely. Thank you.
So at this stage, what would you offer her? She's had 1 shot of hyaluronic acid. We've had this talk where Dr. Sachin and yourself briefly touched on this subject. So first tell me, what is your criteria when you pick a hyaluronic acid injection? What are the criteria which you're looking for? Because here in India, we've got HA, which is, a weekly basis one. You've got 1 shot, which is 6 ml. You've got 1 shot, which is 4 ml. So it's quite confusing. What is your take on this? And then what would you offer her?
Okay. I want to first thank Dr. Joshi for being here as a diabetologist, because his brilliance is there. I want to say that I first of all agree that I love 6.5 as a hemoglobin A1C, but I'm not afraid of a steroid injection. I think it's important for our audience. For the hyaluron, I like the high molecular weights only. I like the non-avian, so biological fermentation, because those that are cross-linked with formaldehyde, when I was a younger man, gave me the pseudosepsis. And although it's the most popular one used, I won't. And so I don't attach any financial needs. I showed the one slide that I think the monovis type, if available, is good. High molecular weight, not cross-linked like that, and biologic is the one that I select if I'm going to do the combination injection. In this woman, I totally agree there are ways to get her diabetes in control, but I'm fearful that she's not going to lose the weight. She's a young woman at 48 years of age, and I also don't like her posterior slope. on the lateral film, which is very common in India. I've learned because you've all taught me how to deal with that. We don't have it as much in the United States like that. So I'm ready. If we wanted to do one injection, again, getting her ready for the operating room, which would mean lowering her hemoglobin A1C simply by some of the new medicines that Dr. Joshi talked about, some of the activities to get her walking as much as possible. She's not going to change a lifestyle at 48 years of that nature. And then it's time to head towards the operating room. And I don't know if you want to take it. And I do believe 20% of my patients, that is the 20%, the diabetics, are all with osteoarthritis. And I don't think we do a good enough job nationally to make that clear.
So the question is now, we do not have this ready-made injection of hyaluronic acid with steroid available here. And if surgeons wanted to, if the surgeons wanted to inject here, what would you recommend? What combination would you recommend?
So my standard since 1994 is I take a 10 cc syringe with 5 of lidocaine, 5 of marcaine, because I want the patient walking out of the office smiling. And usually it takes a few days for the hyaluron to kick in, or the steroid. I use a very small needle, a 25 gauge, 1.5 inch needle. That's why I have an arthritic thumb rather than bigger. But I have to switch to deliver. So I then inject the hyaluron with the leg over the side at the medial portal, aiming to the notch. You do have to switch to a 22 gauge to deliver some of the high molecular weights so you can numb up the skin. I use a hemostat, keeping the same needle in, and then I put the triamcinolone hexacetonide right in to follow it as a chaser, so to speak. And so suddenly I've created, without spending the money on the commercially available product, without a problem every time.
Okay. So coming back here to Dr. Sachin, what is your feeling now? Do you think, is there anything more which you can offer her conservatively, or she's burnt her bridges and now she's heading for surgery?
I think probably the other thing that I would add is that her knee definitely looks at varus. So, as an adjunct, probably I'll give her an offloader brace to try and improve her outcomes. So I think when you're looking at treating these people non-surgically, you have to literally throw the kitchen sink at them. You have to use everything that you have in your armamentarium, because, if they feel good, only then they would be motivated, and then, they would be happy with losing that extra weight and, trying to have a better lifestyle. So in my practice, I think I would do all that has been spoken before, but I would also add an offloader brace for her.
So Dr. Kevin, in your practice, are you using the offloader brace quite a lot? The ones which we have here in India are quite bulky and expensive, and most patients will buy it, but we find that in clinical practice, they're not happy wearing it. What is your feeling?
So well said, that I wish I am a medial compartment narrowed osteoarthritis from too much running as a young man. I wasn't so smart. So I searched out the offloader brace, and for me, there is one that is lighter because most of them are very heavy and the patient does not wear them. So you're very accurate. And but I have found one, and I'm not here to propose, that you get it. But there are some now that are being made lighter for long distance runners. The problem is the obesity. Fitting an unloader brace on an obese thigh is a very difficult thing, I have found. And so I don't have success. So I guess I'm spitting back the same concept that it's difficult. You can do it. I think theoretically it's wise to try, but I don't have high expectations that the wearing will be there. I think the expectation is leaving the office with the marcaine and lidocaine and no pain, and then hoping it is with a smiling patient says, if this is what you want, we can make this happen. And hopefully this will be long-term now, but if it's not, we have solutions.
Okay. So last but not the least, Dr. Rajesh Gandhi, what would you offer her now?
This is a catch-22 situation. You do, you are doomed. You don't do, you are doomed. Now, what are the options with you? Whatever, all the options which has been discussed about can be tried. It may or may not have effect. Like a obese person, she is not able to walk, she is not able to do the daily activities because of the obesity and because of the arthritis. So you have to do something for the arthritis. I think all the conservative approach has been exhausted. We are left with very little option over here.
Okay. So, Dr. Joshi, can you hear me? So we orthopedic surgeons are quite simple and we just talk of BMI. In your endocrine world, there's a lot of talk about sarcopenic obesity versus non-sarcopenic obesity. Do you feel there is any value in grading such patients following your dual absorptiometry scans, etc.? Or is it just confusing the matter further?
No, I think from an orthopedic standpoint and a rehab standpoint, it is very relevant. We know that we are Indians and we are sarcopenic. So our problem is sarcopenic obesity with diabetes. So our muscle mass is very less and our protein intake is very less. So when you are going to do any intervention, surgical or non-surgical, in the rehabilitation and recovery process, having the right amount of muscle mass and appropriating the right amount of protein is very crucial and important. And therefore, sometimes subtyping somebody sarcopenic versus non-sarcopenic is very useful in clinical practice. So I think it's a reasonable option. For that, you really don't need a DEXA bone density scan. If you are an Indian, you are likely to have less muscle mass in general. And you can do a simple subscapular thickness. You can do a simple hand grip test to identify whether there is some degree of sarcopenia. We have simple scores which we can evaluate. But it is definitely useful that if you have a sarcopenic obesity, then you need to enhance the protein supplementation so that the likelihood of recovery is better and handling of glucose is also better, because the outcomes ultimately depend on that. And that's why it's very crucial to identify this. So I'm happy that you got out this point, and even orthopedic world is recognizing the importance. You all know the importance of muscle mass better in the musculoskeletal health, much more than the rest of us.
Okay, right. So let's move ahead now. So we spoke about this. So diabetes and OA, look at this meta-analysis again. OA prevalence almost 30%. So the risk of OA was greater in diabetics than non-diabetics. So this point is very well proven and taken home. And basically, this is the pathogenesis. Diabetes causes local toxicity as well as systemic toxicity. And you see the matrix stiffness, the subchondral bone abnormality, chondrocyte synovial activation, all this causes diabetes-induced OA. On the systemic side, you've got a low-grade inflammatory process which is ongoing, coupled with neuromuscular impairment, and therefore you've got a double whammy causing OA. So diabetes is an independent predictor. So next point. Now, what is the implication of intra-articular corticosteroid on glycemic control? So let's get Dr. Joshi back on. Do you encounter patients or do you counsel them when they come to you with OA and they say, Doc, can I take a steroid shot? How do you look at that situation?
So we often get referrals, and we reassure them that if it is an intra-articular steroid for next 2 to 3 days, that is 48 to 72 hours, you may need much better monitoring. And now we have, this non-invasive methods like the AGP, the Abbott Libre Pro, etc., where you can just swipe and get your glucose value. So probably 48 hours you need to monitor the glucose values, and particularly now with the newer triamcinolone hexonide, the likelihood of glucose going up is there. 2 take-home points: don't keep the glucose above 200. Try to keep it below 200. If it is around 150 as an average glucose, it's great. And just modify the medications for the 2 days. After that, pretty much things are okay. So I don't see a major challenge. If your A1C is very high, I even get sometimes patients with A1C of 9 and 10, and they are in excruciating pain and disabling pain. We still go ahead and modify the dose of insulin or OHAs for the next 48 to 72 hours by a little more intensive monitoring and keeping in touch with us. We are able to handle that well. So it's important to recognize that diabetes should not be a contraindication for helping a person in agony and pain and functional disability. And it's important to monitor them for the first 2 to 3 days, and most of them settle down after.
Okay, thank you. Now, Okay, so does intra-articular steroid injection affect glycemic control? Yes, but the importance is minimal. A single steroid shot produces acute hyperglycemia for 2 to 3 days in patients with diabetes who otherwise have got good control. So what Dr. Joshi said is right. High HbA1c, sugars over 200, big red warning signs, don't go ahead. Intra-articular steroid shots into the shoulder may briefly raise postprandial but not mean glucose levels with larger and repeated doses. Next point. What precautions should we be taking before and after steroid injections in diabetic patients? So, Dr. Kevin.
Yes.
So in your practice, when they walk in, I know you like small needles and small syringes. What do you tell them before giving the shot? Do you counsel them and do you take a special consent? And what do you tell them after they've taken the shot? People often like massages, ice packs. They like to put their leg in certain positions. Do you give them any particular advice, or is it just get in and get out?
I'm not a hit and run kind of physician, but thank you. So I think it's important building a relationship with any patient. I do counsel the diabetic patient that we are going to go forward with an injection, and that first of all, infection is important. So, whether it's betadine or alcohol, so you do it in an appropriate fashion to do the injection. And then because I don't trust any patient, I always give them right there an anti-inflammatory with a sip of water, like Jack Nicholson did, One Flew Over the Cuckoo's Nest. I watch them swallow it, so I know that as they leave my office, there won't be any type of swelling or flare. And I do not counsel them on icing, but I do counsel them that they have to monitor their glucose level, just as you pointed out and Dr. Joshi pointed out, for 48 hours to 72 hours. And we usually have a nurse call where we are in New York City. It's a different beast. And so they check on our patients at 3 days that they're fine. But it is about that your sugar could be elevated and I want you to monitor it. And they usually say, I don't know what you're talking about. Nothing happened. I'm not going to inject a hemoglobin A1C of 9 or 10. So I ask if it's a diabetic, how long they have it. And most chronic diabetics know their hemoglobin A1C number, and they're not about to misrepresent it.
Okay. So important points. Before the procedure, you must take an informed consent. Tell the patients that for 2 or 3 days, there is a potential that the sugars may rise and they need to keep a watch, particularly if they've been labile. Although a safe cutoff value has not been established, most people would agree, the endocrine world, that blood glucose below 200 is preferable. So you've got someone with HbA1c of 8, 8.5 with higher than 200, be wary and don't inject. The other point is the number of joints injected should be considered. It's very interesting. If someone comes to a rheumatology clinic and gets his wrist as well as the elbow injected, that does not seem to affect the hyperglycemia mode vis-a-vis when you inject the large joint. So shoulders and knees, they have a different physiological effect on the body compared to the smaller joints. Okay, let's go on to the next case. This is interesting. So we've got this gentleman, he's about 55. I just saw him last week. He was referred to me from another state, polytrauma, bilateral knee injuries. He was operated a year and a half ago at the Primary Institute, and he had a left proximal tibia fracture that was fixed, and he had his ACL reconstructed. He also had the right side Schatzger bicondylar fracture, which was fixed and operated 3 times, and you'll see how things have gone. And now he's come to us with a lot of pain, but good function. So what do we do? So this is the gentleman. You can see his knee range on both the sides, reasonable flexion. He's able to walk. Let me see if this video plays with him walking. Yeah, you can see him walking. So he is lurching a bit on the right, but otherwise not too bad. Now, we don't have his x-rays pre-surgery. So unfortunately, the Primary Institute had kept them, but this is the sequence which I could collate. So March 21, he had both sides fixed. Can you see the x-rays, Dr. Kevin?
Yes, I can.
So on the left, we can see he's had an ACL reconstruction. He's had a long plate put in, right side bicondylar fixation. And as we go down further, June 21 on the right, you can see there's a crevice and a crack which is expanding, slight joint line reduction. The surgeon there said, we'll wait. On the left side, you can see that there is now callus formation. ACL in situ, he began walking. 11th September on the right, things are beginning to go a bit pear-shaped. On the left, again, you're seeing some callus, but he was coping. And so that's again October, left and right. 11th December, screws are beginning to penetrate into the joint. There's a hint of varus on the left with his healing. And 18th May, so these were the last x-rays which we had, the right and the left one. So let's start with the left knee first. I'm going to ask again Dr. Dilip Shah, what would you do for the left knee? Let's focus for the moment only on the left side. What would you offer him? He's got good function. You saw how he was walking, but he's got pain. In fact, he has more pain understandably on the right compared to left, but both sides are painful. So in terms of conservative management, what would you offer him now?
Thank you very much for giving me the easier side first. So, as you can see that there are no signs of infection, or if you're worried, you can get C-reactive protein and other parameters like ESR. And since you mentioned he's not a diabetic, so I can go ahead with triamcinolone acetate, hexaacetate, and as usual, I would combine it with a visco supplement injection, which is of high molecular weight and highly cross-linked. I don't know what was the reason for Kevin Plancher not to use the avian type. I don't know, it makes a lot of difference, or bacterial is better. He can clarify on that point of view.
Okay, so let's get you in, Dr. Kevin.
Sure. So in answer, first, respectfully on the avian, in my personal experience, I was an avian user years ago, and those are the ones that I got for pseudosepsis. And in the literature, the only ones that show pseudosepsis, meaning no white cells, but this flare reaction, and they were in patients that were rheumatoid. So I will say, I think there is a combination of the body that's never been reported by any other company's HA or in the literature. So I have shied away from it. That's the personal experience, but I know others have had great success with it. So that's why I say that to you. And I think it's the cross-linking of the formaldehyde in some people that get this reaction, and it's well written in the literature. That's why. In answer to that specific question.
A corollary to this viscosupplement injection, rather than Hyalgan GF20, there are some with combination of sorbitol. Would you elaborate on this? Would you prefer sorbitol, like Synolus?
Yeah, I would. I think you're onto something. You're discussing the more second and third generation HAs as opposed to what I was implying when I said avian. Let me be very clear. The first generation ones that came out years and years ago in the 80s and 90s. The first ones. I'm trying to stay away from names. So.
Thank you very much. I think that combination would work of the newer generation of viscosupplement, because it's an arthritic joint, because of the geometry is not all right. So if this succeeds, then you may repeat after 6 months. Otherwise, you will have to, when it is consolidated or not, remove the plate and bring it to valgus later on, if this injection doesn't succeed.
So Dr. Kevin, again, sticking to the left side, what would you offer this gentleman at this stage? Do you think the fracture has healed in the first place? I know you do more arthroscopic work and not trauma.
No, I unfortunately was a traumatologist. So I want to say, first of all, the people in India and all the surgeons, my hat is off to you, because the level of motor vehicle accidents and your skill set is outstanding. So this is, for me, a hypertrophic non-union. I haven't heard yet if the pain is in the joint or the pain is from the fracture. And so for me, I first would approach this in fairness with a lidocaine injection in the joint to say, does that end your pain? Because I really want to distinguish between the two. Clearly, I see the narrowing of the joint, and I see the callus formation, but I haven't figured out where the discomfort is coming from. So I want a selective injection first before I proceed with a final answer for you. So did you do a selective injection, or that's not what someone did?
No, okay, fair point. No, I have not injected him. In fact, he just, this was last week. So Dr. Sachin, what is your feeling now? Left knee. I must say that the ACL is still secure when I examined him, but he was complaining of joint line pain more than the fracture side pain. And you can see the function on that side is pretty good.
So a couple of things here. I think, you definitely need more information here. A long leg film is what I definitely want because we need to look at alignment. I would also do a varus valgus stress X-ray to check whether there's any ligament laxity. His ACL seems to be a transtibial ACL, depending upon the way the suspensory button is looking. So whether he's got any instability there is what I want to see. His lateral X-ray does suggest that probably his tibia is anteriorly translated. Of course, it's not a true lateral X-ray, so I really can't comment on that. So based on what we see right now, I think I would need more clinical information. Excellent point made by Dr. Plancher, saying that we should have a good lidocaine injection to try and see whether the pain is coming from the joint itself or is coming from the fracture or any other cause. So I think these are the couple of things that I would definitely want to look at before making a treatment plan that should help him tackle his left knee.
Okay, Dr. Rajesh Gandhi, left side, your thoughts on this?
I think everything has been elaborated upon. There's nothing more to add from my side.
Okay, so Dr. Kevin?
Yes.
Let's focus now on the right. Any thoughts what you would offer him now?
So, thank you so much for giving me the easier side. The right side, unfortunately, was a valiant attempt to put together a very complex Shatsker fracture. I think it's time to know that this is now a year and a half, and so this is an atrophic non-union, and the biology is wrong. And so I'm heading to the operating room for a takedown, for realignment, for helping him, because the ultimate goal here on this knee at this young person is going to be a total knee. And the ligament, I think on the medial side, there's going to be problems with it. I don't know if it's incompetent there. And so I need a redo because I'm concerned about the medial side of it. I don't know if that bone's dead. I don't know if there's an infection there. So I think it's standard. Identify if there's an infection first. Go take it. It's atrophic. We have to supplement it with appropriate things to let it heal. And so that's where I would start. And I'm sure the skin wound is not easy as well, because I'm sure they did 2 incisions on this. So a very difficult fracture.
Yeah, so if I just go back here, you can see his incisions there. From what he told me, he had friction burns, and the whole thing was like an S-char, which sloughed off, and eventually it healed with dressings. He's had 3 surgeries. So the screws initially had loosened out. So he tells me that the surgeon went in and re-sighted the screws. He also then had a bone grafting procedure. In fact, both his iliac crests have got marks. So that has been harvested. And the 3rd time they took him down for some form of a PRP injection, what I gather, again together with a regrafting procedure. So he's had 3 interventions. This is his skin. And this is what he's now left with. So that fills you up on the current scenario at the moment. Any other thoughts now after this?
Yeah, it's time for a plastic surgeon first. to come in, and we have to raise some more skin. It's probably going to be a free tendon, something transfer. We have to get in there safely. So assuming, it's a big assumption that it's not infected, but I'm concerned with what you said in the multiple interventions that it is. I think it's time to span it. Well, I have to take, whether I like it or not, that medial plate off. I have to take those little screws out of there, and I need to redo it and hope that it's not infected. And even if it is, afterwards have the plastic surgeon raise some flap on it, because I'm going to come back to rebuild it, and I might have to take a hemi-plateau, but I don't know that you do it in India, but we would get an allograft at this point, maybe if it's not infected, to rebuild that, to get a surface before I go into a whole distal femur replacement, you know, or something of that nature.
So two questions at this stage. You do a lot of arthroscopic surgery. What do you find is the difference when you see the cartilage which is scarred post-trauma vis-a-vis the cartilage which is destroyed due to a degenerative process, number one. And number two, if this gentleman comes to you and says, Doc, I've had 3 surgeries, my whole joint is destroyed, why don't you do some kind of a replacement surgery? What would you say to that?
So, answering the first question, the presence of global thinning, like as we lose our hair, is someone that has degenerative process as a traumatic where there is isolated problems. The lateral compartment, I bet, may be thin, but not bad. I'm looking at it. But I'm stuck with a problem, and so you said, why not put the whole prosthesis in? He was 50, I think, or 55. I don't remember the age of this patient. But he's a young man with a quad avoidance gait, with a flexion contracture as he walks. And yes, he's going to get that prosthesis doing it, but I think I would like a better foundation, and the foundation can be built by, I think, fixing that plateau on the medial side before proceeding with that artificial prosthesis. If he was 70 with this, yes, I'm bypassing it and I'm building it up with a custom implant. I'm sorry, that's very costly on the tibial side, and I'm going and I'm bypassing all of this.
Okay, so Dr. Sachin here on the right side, what would you say would you do now?
So here the main concerns are that the medial side seems to be non-viable. A good CT scan would help show if there's any cartilage, the good subchondral bone there, but I really doubt that because the screws have penetrated through the articular surface and now are predominantly intra-articular. So definitely for me, he gets a knee replacement. He's going to get a stemmed implant, but I'm going to do this as a 2-stage procedure. Reason being, he's had 3 surgeries, and so even if he's not overtly infected, you can definitely, there's a good paper that shows that almost about 30% of these internal fixations will grow some bugs when you culture them. So I'm good. In the first stage, I'm going to get rid of all the hardware. That's also going to help me understand what sort of skin behavior are we going to be looking at. As Dr. Plancher has suggested, a plastic surgeon gets involved right on day 1. Exposures are done with his help. All the hardware comes out. We're going to get deep cultures. We're going to get bone cultures as well. And then we will wait till everything becomes quiet. And then for me, he gets a knee replacement. He will have a stem on the tibial side. I will also keep a metaphyseal cone on the tibial side as well. And based on the collateral integrity, I may opt to do cruciate retaining, a cruciate sacrificing with a constrained prosthesis as a backup. So that will be my plan. I'll be doing him as a 2-stage procedure.
Okay, so interesting thoughts, whether to conserve, whether to refix, whether to consider mega prosthesis. Okay, let's go ahead. So we spoke about this, what can be offered? So the jury is still out. I have told him that we'll try one more attempt at reconstruction. He's still young and he was walking well, rather than diving in for a knee replacement. And also the incisions are not going to be easy for a total knee. So The next case, I think we've got enough time for one more case. So we've got this chap, he's about 65, retired school teacher, known case of OA since 5 years, presenting with right knee joint pain. Patient was in conservative management with oral analgesia, gels, and he's tried some Ayurvedic preparations as well. Further evaluation suggested that he had low vitamin D together with osteoporosis, which we often see in this country. And he had a lot of pain, crepitus deformity, and difficulty in walking. So this is the X-ray of the gentleman. I will just give you 10 seconds to digest this X-ray, and then we'll talk about the issues and get Dr. Joshi in as well on this. So moving ahead. So Dr. Joshi, are you there with us?
Yeah.
So when we see osteoporosis and concomitant osteoarthritis, what is your feeling? Would you treat osteoporosis first, wait for a time, and then contemplate surgery, or operate and initiate osteoporosis treatment simultaneously? What do you recommend?
I wish there was a clear-cut answer for that. Now, this particular case has three issues. One is osteoporosis, severe vitamin D deficiency, almost amounting to osteomalacia, and osteoarthritis, which is pretty disabling. So if the disability is overwhelming and surgery is impending, there is no contraindication. We can always go ahead and simultaneously treat both the D deficiency as well as the osteoporosis simultaneously. Ideally, I would keep a gap of between 2 to 6 weeks for a case like this. I would definitely load them with mega bolus doses of vitamin D and get at least sufficient vitamin D on board. I would definitely do a PTH and calcium to see whether there is no autonomy of the parathyroid glands. And once the D is at least 20 or 30, I would definitely get on board. And I have three options for the osteoporosis treatment. All three are excellent options. Maybe 10 years back, the only option I had probably was to give them an injectable zoledronate if there is no contraindication. Then, of course, came the teriparatide. Both are excellent options which are available. And the third option is the option of denosumab. Zoledronate has been best studied in this case. And the likelihood of its impact in terms of healing, long-term outcomes probably may be better. That was the data available with us maybe a decade or decade and a half back. Current data is pretty compelling in this space, both for teriparatide and its newer analogs, which may get available in India soon, as well as for denosumab. So we use all the three of them pretty liberally. The advantage of zoledronate is it's once a year or once in 6 months preparation. So is that with denosumab. It is, of course, zoledronic acid is very cheap compared to denosumab. So the cost comes into the picture. And teriparatide is still economical, but still not as economical as a zoledronate. So all the three options are equally available. All the three have data. In the arthroplasty space, very clear data is available on better healing, etc. But having adequate D on board is crucial. If you don't have adequate vitamin D on board, your likely outcome of surgery is going to be weaker and poorer. So my thinking is very simple. Get sufficient D onboarded and start or initiate a anti osteoporotic regimen. Easy is just to give a zoledronate, and after 2 or 4 weeks, take up the patient for surgery. That's what I would do if if this particular case presented is right in front of me. But there could be all the three views, and there could be pros and cons for all the three of them.
Okay, so Dr. Kevin.
Yes. Ready?
So what is the view in North America? How would you go about? You've seen the X-ray. I'll just go back.
Yeah, I have. So this is someone that has had long-standing valgus deformity, and so I think I'm going to. I heed the advice of Dr. Joshi. So it's 5,000 units of vitamin D starting today, with 1,000 micrograms of folic acid to increase the absorption of vitamin D, because vitamin D is so difficult to absorb. I think it's not going to move it that much, but I'm going to put it on the vitamin D because I'm not going to wait the 1 year. I'm going to give an injection of triamcinolone acetonide that day to give relief to the knee, which may or may not give relief. And he's being put on my OR schedule for a Cruciate sacrificing, total knee, warning him about the peroneal nerve and watching because 8% of patients can have problems afterwards when straightening them out. And I think he will love what his new leg is going to be, and he'll come back to deal with the left one.
Okay, point noted. So going ahead, osteoporosis treatment and arthroplasty. Interestingly, bisphosphonates, teriparatide, and denosumab all seem to be having a very positive impact in terms of preserving bone mineral density and preventing peri-implant and post-surgery periprosthetic fractures. So I think what Dr. Joshi said was a very, very valid point. Get your vitamin D topped up pretty quickly. Start concomitant osteoporosis treatment as well. But then osteoporosis, arthroplasty and osteoporosis could go hand in hand. Now, what is the impact of vitamin D deficiency on arthroplasty and post-operative muscle strength and rehab? Any thoughts on this, Dr. Joshi?
I'm a big D believer. You know, my guru in the US has been Mike Holick. I've written chapters with him. And I feel that we need to have, 25 OSD at 50. That's my goal for everybody, all human beings on planet Earth. So I'm very clear about it that, a D of 8 is abysmal. So as Kevin was saying, I would give a 6 lakh unit of injection for this individual to get things onboarded. We have it available in India. Give him intramuscular. Absorption won't be an issue. At least I know that there is some vitamin D onboarded on this patient. And in terms of arthroplasty and post-op muscle rehab, clearly, the higher the D, and I don't look at 50, I target, I don't look at 30, I look at 50. Clearly, the outcomes are outstanding. So the musculoskeletal outcomes of correcting D and the data on it is overwhelming. The non-musculoskeletal outcomes, like in cardiometabolic space and other outcomes or autoimmune diseases, are reasonable, but they are not beyond reasonable doubt. So I feel that in your space, which is musculoskeletal health, which is what all of you all do, I think the benefits of D clearly outweigh the non-correction, particularly in cases like this where the D is so low at around 8. The only challenge is once you have corrected, D is a fat-soluble vitamin and stays in the blood for a long time. So we need to avoid toxicity, particularly in 2 cases. One is very senior individuals and people who have kidney disease or diabetic patients or hypertensive patients who take renal non-friendly medicines. So or they take a lot of painkillers. So if somebody is on a lot of painkillers or NSAIDs, is a diabetic, hypertensive, has some borderline creatinine, then the D suddenly can shoot up. So be a little cautious there after you have done the primary correction. But I think it's a no-brainer that you need to have adequate D on board.
Can I just say kudos to you, Dr. Joshi, because I aim for 75 to 80 in every human being on the planet. And I'm so annoyed at the number of 30. So thank you for what you just justified, I say. And so thank you for that.
Okay, so let's just go ahead. Now, what is the impact? So vitamin D status and arthroplasty. Low vitamin D will result in longer hospital stays, more complications like periprosthetic joint infections. TKAs have significantly worse outcomes if your vitamin D is low. And very interestingly, vitamin D deficient mice with intra-articular knee implants had increased bacterial burden and increased neutrophilic infiltration. So vitamin D has widespread manifestations in terms of orthopedic procedures. QMS, quadriceps muscle strength, correlates with serum vitamin D and knee pain. So the punchline here is for each 1 nanogram ml increase in serum vitamin D, the value of your strength increases by 14%. So well worth treating your patients before you take them up for arthroplasty if they are deficient. Now, I know it's 9:30. Dr. Kevin, are you okay with us for one more case, or do you want to take questions from the net? How are you placed on time?
They want me somewhere, but I would like to take the questions and we'll see what we can squeeze in the case. So it's your choice, so we can squeeze in the case. That's okay. You're offering such great concepts that I'm sitting here learning. So I'm loving it. So I'm jealous as well.
So, our audience count is immense and they've sent a lot of questions. So I'm going to get Dr. Milind to get some questions from the net, which we are constantly receiving on the chat box.
Okay.
So this is a question for Dr. Kevin. If he injects all his knees during arthroscopy with steroids, is that his standard practice? So
someone has, I know what they're asking. Someone's been stalking me, so I love it. There's someone out there that, because there's no way anyone would know my personal things. So I'm going to tell the audience, because the article will be coming out, that because of my mentor, every arthroscopic intervention since 1994 has an injection of steroid with Marcaine in it for any patient so that they do not have swelling, they move, and I do not use a tourniquet either, ever.
Okay. Next question is, can you comment on the risk of chondrolysis following steroid injection? So do you see that with your THA?
So I knew, as I intimated in my talk, and I'm aware of the basic science studies from Connie Chu and others, I have never seen degradation. I'm now in practice 28, 30 years, and I require all my patients for yearly follow-ups. It's one of the rules of having surgery, no hit and runs. I have not, to this day, I'm knocking on wood, seen chondrolysis. I am aware of the studies, but I do not use indwelling catheters. That's a different story. And so I'm very confident that this is not, even knowing the pH, going to be any factor for chondrolysis.
Okay. Another question from Dr. Imran. He says, is there any role of arthroscopic abrasion arthroplasty in OA? Do you do that often in your practice?
So once again, people are doing their homework. I am a student of Dr. Richard Stedman, who invented the microfracture technique, which was an absorption of the abrasion arthroplasty by Lenny in Michigan. And so the answer is, I think there is a big role for microfracture, understanding that we're not creating the type 1 collagen, it's a type 2, and we're not creating the original collagen now in the knee, but we have to critically look at, we've adapted the new generation microfracture picks that are much smaller than giving this bigger holes. And so I think, yes, there is a role for patients and you should use it.
Okay. Another question from Dr. Samir. It says, do you find any advantage of using a PRP with an intra-articular steroid injection? So a cocktail of PRP with steroids. Have you tried that, or do you feel it's going to be worthwhile?
Yeah, so the answer is the science is coming out of Rush that it is helpful and there is good science. The problem that I have in my area, it's not covered by insurance, and so it's a cash-paying incidence, and therefore it is not used highly in my region. We are hoping to change that, and I bet the combination of those with HA, PRP are going to show it. It is not effective in some other joints like the hip, but at the moment in the knee, it seems to be, or in tendons, it seems to be helpful more so.
Okay. Another question from Dr. Kulkarni. He's asking us whether would you consider PRP as your primary choice even before a steroid injection, and if so, in which conditions?
So the answer is, again, I am biased, and it's not because I'm here presenting today for Abbott. I am not a PRP primary user. There are many doctors that are, and so if you got someone, I don't want to give names, there are people that are primary users. I find that the simplicity, the cost, and as I said, it's not in cash, that it's a great result for patients that give for years safety profile. And so I am a big fan of the intra-articular steroid as my first line, and the literature supports what I'm saying as opposed to PRP.
Okay. Another question, this is pertaining to arthroplasty. So since you do a fair amount of replacements as well, the question is from Dr. Bhavin Kothari. He says, is it a common practice to inject steroids as well as a part of your cocktail therapy at the end of your arthroplasty procedure? So do you routinely combine steroids with anesthetics as well when you're injecting?
So when I do a total joint arthroplasty, I am using a periarticular injections made by some other companies because we only do outpatient. I only have done outpatient for the last 6 years for all total knees, no matter what the comorbidity is. So I need pain relief. And I haven't seen the necessity for swelling or what. The periarticular injection, though, has in it a combination of antibiotic, saline, the actual product, the Exparel type product, and an antibiotic. So no, the answer is for my total joint arthroplasties, I don't use triamcinolone hexacetonide, but I do know some doctors that do, but I do not.
Okay. I'm going to ask Dr. Sachin here as well. In your practice, during arthroplasty, are you injecting steroid as a part of your cocktail?
So in my pericapsular infiltrate, I am not using any form of steroid.
Okay. So again, for the audience, routine use of steroids, you've got to be careful. You may increase the risk of sepsis. Okay. We'll take one more question. So there are many ways of acquiring and procuring PRP. Dr. Kevin.
Yes.
So we've got here several companies who are offering you PRP services. The centrifugation time varies, the quantum varies, the cost varies. What is scientific? Is this actually a recommended treatment by the American Academy? And is this really valid, or is this a money-making racket?
So before I get myself into jail and speak on behalf of the American Academy of Orthopaedic Surgeons, we know what's online. I want to say that Sachin really summarized nicely the utilization of PRP. And my answer is that the American Academy of Orthopaedic Surgeons is spending a tremendous amount of money to now pipeline studies that will validate the utilization of PRP and in which joints and if for which osteoarthritis versus tendons. And so today I can say to you that you're correct. We don't know the cell count. We don't know if you need multiple injections, and it's all proprietary. So all I can say is I would encourage you to read the literature, peer review that's there, and the American Academy of Orthopaedic Surgeons has made statements which I'd rather not misquote on the utilization of PRP for tendons, ligaments, and osteoarthritis. And it can be used, but it's used with caution, and there is a need for prospective studies that are going to be started.
Okay, one more question. For OA knees, when you do a arthroscopic washout, in what percentage of patients you are injecting hyaluronic acid at about 2 weeks post suture removal? Do you inject HA post arthroscopies?
Another great question. So I believe the human body needs 5 to 6 weeks to heal after a meniscectomy. I want to be careful. Washouts are not permitted in the United States any longer. They have to have some mechanical problem with it because of the article that was written years ago in the New England Journal of Medicine. So insurance companies will not reimburse. And the answer is I absolutely use HAs as I post arthroscopic intervention, but I don't do it before 3 months. And that's simply because I want to see how the patient is doing, and then I want to sustain them, hopefully for a year or whatnot afterwards, after using the triamcinolone hexacetonide at the time of the operation.
Okay. So I'm going to keep the questions on hold. If you allow me and give me just 3 minutes, I'll quickly run through the last case before we call it a close. Would that be okay?
Sure, I'd be honored.
Okay, so this is a young gentleman. He plays badminton at a very high level. He had a left knee surgery for a meniscal tear. He underwent trimming from what the notes said a year and a half back. He was fine in the interim period. He came back with knee joint pain, and the repeat MR scan showed that he had a tear in the menisci. So what should we be offering him? So clinically, he's walking fine, no effusion, dull pain along the medial joint, and particularly when he jumps and he comes down smashing, he lands with a thud, and that's the time it hurts. Would you offer this gentleman any surgery now, or would you still jolly along with conservative management? Dr. Kevin?
So young people that are highly active, and he's at a national level, and you can see his tibia vera that he has. It is what it is, and he's learned how to distribute his weight force. I don't believe in the redo meniscus. I don't believe it's been retorn. I know what I see or what you're showing me, but I will say that the second time MRIs after a partial meniscectomy, I have found are not as predictable. And therefore, this is someone that's active. He has pretty good weight bearing, as you said. He is a great candidate for an intra-articular one-time injection with some marcaine and lidocaine at the same time to see and say, how does that feel? And we ride it out. We build up his quads. We help him in his landing. You can see in his film his feet are together. That would be terrible for the medial joint line, the weight bearing. And so he has to learn and go to physical therapy how to land with his legs apart to distribute it and to build up his core. And I think he'll do terrific.
Okay. Dr. Sachin, I'm going to ask you, would you consider any form of realignment, osteotomy, coupled with another go at the menisci?
So I think his primary pathology is because of his mechanical malalignment. The meniscus tear is giving him symptoms of catching and locking. If I do any form of realignment, he's not going to be happy if he wants to play ahead. So I think the first is to have a detailed discussion what he wants to do with the rest of his life. Sport like badminton after an osteotomy is not very forthcoming because they don't find it that comfortable to do that kind of sport. So for me, I think a detailed discussion is extremely important. His meniscus tear shows an inferior flap which has displaced into his inferior meniscotibial recess. These flaps can be very painful because they tend the meniscotibial ligament. And for that, I would not shy to offering him an arthroscopy to try and help him. But it will come with a caveat that this is not going to give him long-term sustained relief just because his limb is grossly malaligned.
Okay, fair point. So before we wind up, I'm going to ask Dr. Shashank Joshi, are you still with us? Can you hear us?
Yes, I'm with you.
Okay, so before we wind up, any last words on what the orthopedic surgeons should be looking at before they look at obese arthritic patients?
So I think weight loss is the key, and getting diabetes under control is the key. So I think lifestyle intervention is the key, muscle health is the key, and musculoskeletal health is actually key to metabolic health. So if they have good musculoskeletal health, the orthopedic community is the influencer for building good muscle health, both in short term and long term. So you play a huge role in community service at large in preventing long term complications. So I think and getting the right D on board, ensuring that we need not hesitate with using intra-articular steroids which are safe, like the ones which we have discussed today, not getting worried about diabetes. But I think the key on planet Earth is weight loss. And I think you all are big influencers in weight loss or initiating weight loss, though it's too late. And also initiating a momentum for good muscle health, for better metabolic health. Thanks, Parag, for the opportunity.
Okay, Dr. Kevin, your last words on steroid injection and OA. What is your take-home final punchline?
I would say that osteoarthritis is here to stay and that we should always try with conservative treatment. I think that you've heard worlds of wise wisdom from, Dr. Shah, Sachin, Dr. Munshi, yourself. And I think that an intra-articular injection of a triamcinolone hexacetonide, meaning a longer acting steroid injection, so you're not doing repeat injections so fast, is something to be considered and will give success and make your patients happy.
Okay, thank you, gentlemen. I'm going to thank the panelists as well before I hand over to the Abbott team. Thank you all. And we've got more than 1,800 people on the net watching this program. So, it's quite a good take which we've had. Thank you, Team Abbott. I'll hand over to Milind and Dr. Preeti. Thank you.
Okay, so very good evening to everyone. And at the outset, I would like to thank all faculty members, Dr. Kevin Plancher, if he's there, Dr. Sachin Tapasvi, Dr. Dilip Shah, Dr. Shashank Joshi, Dr. Parag Munshi, sir, Dr. Dilip Shah, and Dr. Rajesh Gandhi. Let me tell you that we had a wonderful scientific feast today. In fact, I'm sure that all three sessions were so insightful that we all are immensely benefited with the scientific pointers which were discussed today. I'm sure that is what even the audience would vouch for. Okay, so thank you once again, sir. I would also like to thank all doctors who have attended today's program. So as Dr. Parag Munshi made a mention of it, we have 1,200 doctors who have digitally logged in. 400 doctors have viewed this relay program at 38 centers across the country, and there are the 200 doctors who have viewed our program on OrthoTV, which is a dedicated platform for orthopedicians of India. We look forward to have many such programs in coming days also. So we'll be circulating a feedback form to each one of you. We request all of you to let us know the topic of interest which you would like to hear in the coming programs. I would also like to thank my medical team, especially Dr. Milind Bole and Dr. Karthik, who has put together the scientific content of this program in coordination with faculty member. So thank you so much. Thanks, doctor, for taking out time and be here with us for attending today's ISP's program. So may I request all of you to now join us for dinner. Thank you so much. Good night. Thank you, sir.